My name is John Githure, working in the Kenyan project of ICEMR. I'm going to give you a presentation on our implementation study titled Adaptive Interventions for Optimizing Malaria Control, a cluster randomized smart trial. There are many challenges that have been kind of presented here that the national malaria control programs face, which I can distill them to what the environment, the human, the vector, and the parasite normally have this very intense interaction. So this complex interplay, of course, is what makes it difficult for malaria control managers to be able to come up with an optimal vector control strategy. And we as ICEMR, we believe that the current and new intervention tools needs to be adapted and readapted to local vector ecology. There are a number of research questions that have been posed by researchers and as well as malaria control managers, and I'll present two here. One, what is the most cost-effective combination of intervention in addition to the standard LLINs that have been in operation for the last 4 decades or so? Number two, which interventions among the next generation LLINs or the new IRS insecticide or even the larval source management can be adopted by the national malaria control programs? We are addressing these problems or challenges with adaptive intervention using the SMART design. The SMART stands for Sequential Multiple Assignment Randomized Trial, which is a design that has been used severally in health, but basically in non-communicable conditions such as cancer, weight loss, depression, insomnia, stopping smoking, and the like. But in our design here, we are going to use it for malaria control and basically for vector control, in which we select a study site, and then we use the available intervention tools in our stage 1 of intervention. And these are basically the LLINs, the PBO nets, and the LLIN combined with IRS, including the new insecticide, the long-lasting insecticides. So we do monitoring and evaluation, in which we have set out a threshold of a relative reduction of 20%, below which we record those clusters as non-responsive, and those that respond are the ones that go beyond the 20% relative reduction in comparison with the LLIN group. So for those that respond, they continue with the same intervention. And for those that don't respond, we add another intervention, or we use enhanced machine learning to at least make them, at least to utilize that intervention and see how it can work. So in total, we end up with 6 subgroups. And all these subgroups, each one of them is compared with the LLIN comparison group in our stage 2 of intervention. And by the end of it all, we aim to come up with an optimal vector control intervention that we think we can recommend to the national malaria control programs. So that is our design, which I'll keep on referring to here and there. But our project started in April of 2019 and will go into up to 2024 March. And we have 2 phases in our project. Phase 1 started in 2019 up to 2021. And then we started phase 2 in April of 2021, and will continue up to 2024. So since the time of the start, we started the project, we have been doing epidemiological surveillance. And this epidemiological surveillance involves active case detection, in which we do bi-weekly monitoring of febrile illness. And this is done by community health volunteers who visit the residents in their clusters and interview them for febrile illness. And for those found to have had fever in the last 2 days or with active fever, their blood is taken and examined for parasite with ultrasensitive RDTs. And also we get filter paper for determining PCR detection of the parasite. We also do we also do cross-sectional survey, which we do every 6 months. And this, we select 50 randomly selected houses from the clusters. And from these clusters, we examine them for malaria parasites using microscopy and also PCR. And this is done every 6 months. For entomological surveillance, we collect adult mosquitoes using pyrethrum spray catch collection, CDC light trap, and this is done on a monthly basis. Whereas for larval habitats, we do characterization of the habitats and also collect larvae, which we do seasonally during the wet and the dry season. We conducted our first pilot study, our intervention, in March of 2020. And our second intervention, we did it in September of 2021, and recently March 2022. And we shall continue with the second stage of our intervention, which is adaptive intervention, after we finish evaluating the responders and non-responders of this particular intervention that we are doing. And we have come up with the outcome measures that we are measuring, mainly primary outcome, which is the reduction in clinical malaria incidence. And for secondary outcomes, we examine reduction in transmission intensity using entomological inoculation rate. We also examine asymptomatic infection prevalence reduction, drug and insecticide resistance, as well as parasite genetic diversity, and also do cost-effective analysis of all the interventions that we shall use. And as I said, we have these two phases of our project, the pilot study that started in April of 2019, and the scaled-up study that we started in April of 2021. So I'll give brief findings in each of the phases, whereby in our pilot study in Nyakach, which is in Kisumu, Western Kenya, it's a high malaria endemic area with high pyrethroid resistance. And our site has 3 distinct eco-epidemiological zones, ranging from 1,100 meters above sea level at the lake shores, Lake Victoria, going through up the slopes or the hilly slope, and then up to the top of the hill on the Nyambondo Plateau, which rises at 1,700 meters above sea level. We work very closely with the Ministry of Health in terms of training the CHVs as well as field assistants. We also work very closely in interventions in distribution of LLINs, both LLINs and PBO nets, as well as IRS operation, and including also sample collection as well as data collection. And we as ICEMR, we do the monitoring and evaluation to evaluate the most effective intervention that we are doing. So based on our prevalence baseline and also vector density as well as incidence rates, we were able to classify the study site into 3 malaria risk zones using multi-cluster analysis, whereby we found the lake zone. The people living in the lake zone are the highest risk of malaria compared to the other 2 zones, the plateau and the slope. And this is after adjusting for the elevation, and which shows that if a malaria control manager wants to minimize or to maximize the resources or the minimum meager resources that they have, then they would definitely want to concentrate on the lake zone. This information is found in one of our publications. And this is just part of our epidemiological and entomological surveillance teams, whereby we have the health facilities, the community health volunteers, the field assistants doing the PSC, as well as CDC light trap collection of mosquitoes. In our study site, which we randomized into 36 clusters, we have 12 clusters per zone. As you can see, we have the lake zone with 12 clusters. we have 12 zones, 12 clusters in the slope and 12 clusters in the plateau. And we randomized our intervention, the 3-arm intervention, in which for each zone, we had 4 clusters that received IRS, 4 clusters that received LLINs, and 4 clusters that received PBO nets. And this was replicated in each of the zones, so that in total, we have 12 clusters that received IRS, 12 that received LLINs, and 12 that received the PBO nets. And these are the intervention tools that we use: the pyrethroid only LLINs, the PBO LLINs, and IRS using pyrimidine methyl or acrylic 300 CS. And this is just showing our door-to-door distribution of nets and our IRS operational team. So in our coverage, in the intervention that we conducted in March of 2020, we achieved a very high net ownership, or high percentage of net ownership, in which we also ensured 1 net for every 2 persons in both the LNIs and the PBO arms of intervention. And we also had a very high spray coverage of 96%, in which we protected, with the 3 interventions, we protected over 16,000 residents. After the intervention, we continued monitoring the effectiveness of these interventions by doing wall biases, by doing net by efficacy, by looking at the net fabric integrity as well as net usage, and also doing insecticide resistance survey and dissecting mosquitoes for checking their age structure in terms of parity in paras and nulliparous mosquitoes. So the results in our phase 1 shows that both the PBO and the IRS clusters performed very well in terms of malaria incidence reduction, which shows here that in this figure, using a baseline of 1, it shows that the nets, the PBO nets and the IRS performed very well in the 1 to 6 months follow-up, and also 7 to 12 months follow-up, compared to the reference LLIN arm of intervention. And if you recall also, we had this transmission intensity as one of our secondary outcomes, which also, looking at the entomological inoculation rate ratio, with the baseline here as 1, we see a very drastic reduction of both the IRS and the PBO clusters compared to the reference arm of intervention with LLINs. And this happened between 3 to 6 months, but then afterwards, that effect or impact leveled off. So as you recall, our incidence reduction rate is what we were measuring the responders and non-responders, and 9 out of 24 clusters did not respond to the interventions, 6 in the PBO and 3 in the IRS clusters. But this is based on the 20% relative reduction threshold that the ministry and us had set in terms of determining the clusters that respond and those that don't respond. And as you can see, even for the ones that responded, the blue ones, we also have very great variation in that some did very well, and while others did just marginally in terms of their responsiveness to the intervention. So with this great variation and the small sample size, we justified ourselves to scale up the intervention so that we can have more statistical power in terms of our analysis. And that's how we moved into the second phase of our study in scaling up, which we started in April of 2021, in which we increased the clusters from 36, if you remember, they were in 3 epidemiological zones, to 84 clusters in 7 eco-epidemiological zones. And also you can see the resident also increased. And with diversifying to Muhoroni from Nyakach in these 2 sub-counties, we have diversity in terms of eco-epidemiological settings, in terms of elevation, aquatic habitats, farming practices, and socioeconomic activities. So this is showing the 7 eco-epidemiological zones, with the 3 that we started off with, the lake slope and the plateau, scaling up to the farmland, inland, plantation, and reserve. And just like we did in March 2020, we randomized each zone to receive 4 clusters to receive IRS, 4 clusters to receive LLINs, and 4 clusters to receive the PBO nets. So in total, we have 28 clusters in each arm that received either LLIN, PBO, or IRS. And just like we had in our first pilot study, we also had very high net ownership percentage, and also ensured 1 net for every 2 persons. And we also had a high IRS spray coverage, in which we protected over 48,000 residents. And you can see here the LLINs were distributed in May through mass campaign. We distributed the PBO in September. We conducted IRS with Actelic in October last year, and again with Fludora Fusion in March of this year. With the species composition, we found that the predominant species is Anopheles gambi SL, followed by Anopheles funestus. But of course, we have continued to do PCR analysis of these sibling species. For infection prevalence, we find that the lake, the slope, and the plateau, which were our initial study sites, have very low prevalence compared with the new sites of farmland and the 4 and the 3 in Muhoroni here, in which we have less than 30% prevalence in our old site, but then greater than 30% prevalence in the new Muhoroni site. So here we can easily say that a national malaria control program within the Kisumu County would want to look at these areas and see how the burden can be reduced to this kind of level. Because when we started our project, there were almost like this kind of burden in terms of prevalence. And you can see also for incidence by ultrasensitive RDT, we also have the same scenario whereby the Nyakach site has lower incidence compared to the Muhoroni sub-county. So by doing multi-cluster analysis, we were able to group these 7 zones into 4 malaria risk groups, with this area, with the plateau and the slope having the lowest risk, and this area with the reserve and part of the inland showing highest risk of malaria infection. So this is what we are trying to do now in terms of trying to decide or to determine, which interventions would be suitable for these particular settings. And that's what we are doing currently in terms of identifying clusters that do not respond to the intervention. We are currently here in terms of monitoring and evaluation, looking at the incidence rates and other outcomes that we mentioned earlier, and then use reinforced machine learning for those clusters that are not responsive, and then do cost-effective analysis of the interventions, and then identify the most optimal vector control intervention for recommendation to the programs. So in a nutshell, what we are doing is that we are looking at malaria risks, and we are also looking at the available control tools as well as the surveillance tools, and also considering that there will be new ones that will be coming to the market, looking at the climate change and environmental modifications as having impact on transmission, and then drug and insecticide resistance, which we also know have impact on transmission, looking at the vector ecology and vector behavior, and then coming up with a cost-effective vector control intervention, but all along using GIS, modeling, and machine learning to perfect and to come up with a precise adaptive vector management strategy. And we hope that at the end of the project, we're going to have an optimized adaptive implementation strategy tailored towards local malaria risk and vector ecology in line with site or region-specific socioeconomic constraints. And thank you very much for listening to the presentation.